Intracranial pressure monitoring. The goal that you will see ordered is to keep the ICP less than 20. Some providers are okay with 22. The reasonable range as a trigger for treatment is an ICP 20 to 25. This value is taken at the end of expiration and recorded hourly or more frequently. Central perfusion pressure goal is to maintain greater than 60. Central perfusion pressure is how much is the brain being perfused. This is the mean arterial pressure subtracted by the ICP. So if your ICP increases, your pressure in your skull cavity is increasing, and that edema and pressure compresses the vascular structures, reducing cerebral perfusion and leading to a decreased CPP. So ICP goes up, CPP goes down. If your blood pressure goes down, this drives your mean arterial pressure down, and your ability to send oxygenated blood to the brain goes down and decreases, and your CPP will decrease as well. So blood pressure goes down, CPP goes down, ICP goes up, CPP goes down. If ICP is being monitored, central perfusion pressure must be monitored and maintained greater than 60 to prevent ischemia and cell death. So this is the Camino monitor on the left, and this is an example of a bolt on the right. So the bolt is what goes into the patient's skull, and it is not MRI compatible. So you can take it to CT, but you will not take the monitor with you. This black end connects to a cord that comes from the Camino monitor, and you would just disconnect that, take the patient down from this black connection site. Where do you get the equipment? You should probably tell the neurosurgeon to go ahead and get their own equipment. You're going to go down, grab stuff, and it's not going to be all of what the neurosurgeon needed. They know where it is. Have them go get it. Tell them to go get it. But this is where it is just in case. So the equipment you need is the Camino monitor, the cranial access kit, the Camino box with the fiber optic catheters. So if you take the B elevators to the first floor, the doors open, this is what you see. You're gonna go through those double doors. So let's go. So you come over to the keypad, you're gonna scan your badge, the doors are gonna open. There's first door on your right is the door you're gonna enter. It's called surgery holding room. You scan your badge here, you open the door, come on. It opens. In the back left, there is another tiny little room with this pull-up bar. You have to do 5 pull-ups before you can gain access to the equipment. That's policy. It's in policy stat. You can look it up. In this tiny little room, you will have a cart with a blanket over it, and it has the ICP monitor that they use in OR, the Camino ICP monitor that they bring up with us. It has the fiber optic cable, the Camino box. This is a teal label, and then a similar box that has a blue label is for the external ventricular drain cable or catheter. So we see a little closer look. Here we see a teal label. If you're thinking external ventricular drain lumen, think blue, fluid, water. If you think fiber optic cable, of course you're gonna think teal. So fiber optic cable, teal. And it says fiber optic cable on it, so that's helpful as well. The bottom shelf, we have a external ventricular drain setup, and we have on the very bottom the cranial access kit. So cranial access kit, the fiber optic cable Camino box, and then the Camino monitor itself. So nursing interventions, you want to take care of the patient, perform nursing care slowly and cautiously. That way you can help manage and prevent increased ICP. So an important part of this is maintaining blood pressure. So keeping MAP within a tight control, systolic and CPP within tight control will really help the patient to prevent increased ICP. This is the most important part of early care to reduce hypoxic ischemic damage. A single episode of hypotension has been shown to double mortality rate with patients that have traumatic brain injuries. So fluid pressors are given to increase CPP to greater than 60 and increase blood flow to the brain if they're having low blood pressure. You want to reduce any straining, coughing, agitation, stimulation. If you're performing anything on the patient, do anything to the patient, warn them, keep a calm, quiet, dark environment, only suction when needed, speak to the patient before procedures. You want to make sure the patient is sedated adequately to prevent all of this. Propofol is lipid soluble, crosses the blood-brain barrier, has a rapid onset and a short half-life. So you often will see this so you can sedate patients quickly, as well as assess them quickly if you need to reduce the sedative as well. You want to facilitate venous drainage and return. And the way we do this is keep their head abed 30 to 45 degrees, keep the neck midline, prevent their neck or hip from flexing, making sure anything around their neck like cervical collars or ET tube ties are loose enough, are secure but loose enough to prevent compression of the veins. Carefully titrate PEEP as low as possible. So PEEP will increase the pressure, the intrathoracic pressure, which decreases venous return and increases your intracranial pressure. You also want to optimize ventilation. So you want to keep the patient's O2 normal and their CO2 low to normal. We used to think that we would hyperventilate patients, and that was effective because it causes vasoconstriction when you're hyperventilating. But this has been found to cause overconstriction and lead to ischemia. So current research supports keeping the patient normocarbic, a low normal level of 30 to 45. You also want to maintain normothermia. Hyperthermia, fever is detrimental to the brain. It impairs energy metabolism, disrupts the blood-brain barrier, and increases the release of excitatory neurotransmitters, all of which increase ICP. So we can use the Arctic sun to maintain normothermia, ice packs, cooling blanket. Why not hypothermia? Why not cool them? Because fevers are bad. Larger randomized trials have failed to demonstrate that this results in improved outcomes. So let's think of the side effects that come with hypothermia. We have shivering, we have dysrhythmia, we have increased blood viscosity, and it can exacerbate coagulopathy and acidosis in trauma patients. This is just an order set. I wanted to include it on here from our order set. You see ICP greater than 22. Let's look at where to chart ICP. So you chart it in neuromonitoring. So under vitals and pain, you would click neuromonitoring. And if you have already charted your blood pressure and your mean arterial pressure in vitals, your CPP will auto-calculate. Let's say your MAP is 80. What would your CPP be? No, your MAP is 80. Your CPP would be 66. I have those in the wrong spot. So you're within your goal. Your MAP is 80. Your ICP is 14. You subtract your MAP from your ICP. 80 minus 14 is 66. This was a document provided to us by the neurosurgery nurse practitioner as what you should be doing and what information you should be preparing before calling the neurosurgeon for an increased ICP. I wanted to include it on this. I want to check in with the neurosurgeons to make sure that we update this. So with, for instance, checking ABG, checking sodium level, checking osmolarity, are we just finding out the most recent and what time it was and whether it's been recent? Do they want us to have standing orders so we can draw an ABG? And that, keeping that in mind, if you have an increased ICP, if you tried your interventions and it's sustained, you're not going to draw a sodium level, wait for that to result before you call the neurosurgeon about it. You're going to call. So, so just have this information ready prior to calling the neurosurgeon. Let's talk about ICP waveforms. Knowing a little bit about ICP waveform analysis is important. You can identify when compliance is being lost due to compression on the brain. So your ICP right now is 10, around 10, that's normal. When you have a mass in your brain, a smaller mass, or an injury, your ICP goes up to 15 maybe, which is a compensated state. So you can compensate with an ICP of 15. Your brain, in your closed skull, your brain makes up 80%, your CSF makes up 10%, and your blood makes up 10%. In a compensated state with an ICP of 15, your brain can't go anywhere, it's 80%. Now your ICP is increasing because there's a mass or a bleed taking up space. So your blood is going to decrease, and your CSF is going to leaving you maybe with 5% of each, and then the mass would take up that. So now you're in a compensated state. Your ICP goes up to 20 or greater, 22 or greater, 25 or greater. Now you are in a decompensated state, and knowing about these waveforms can tell you when you're entering that. P1 is the pulse of the arterial artery. So this is going to reflect the ejection of blood from the heart going up into the brain. P2 is reflects the compliance of the space in receiving this arterial blood. So you have your intracranial bolt, which checking your ICP. You have a squeeze of the heart and ejection of arterial blood into the heart. The bolt registers this and shows you P1. And then the response to the space in your skull shows a waveform of pressure. And this is showing the compliance that your skull has in accepting that pulsing of arterial blood. So now you can guess that if P2 is increasing, your compliance is going down because it's showing you more pressure. So let's look. P3 is aortic valve closure, not as important. So compliance is worsening with a waveform that tells us about compliance. P2 increases and is equal or greater than P1. So the brain is unable to compensate for an increase in volume. If you see this, this might be the time you want to limit care activities that would increase ICP. Wait to give the patient a bath. Don't reposition them. Don't suction them if you can help it. If you're seeing a non-compliant brain, you're going to see a plateaued waveform. So here we see A waves and B waves. What makes it an A wave versus what makes it a B wave is the millimeters of mercury on the left side. So we see that the B wave is around 30 millimeters of mercury, and the A waves are between 50 and 100 millimeters of mercury. So your compliance is worse. So the brain is unable to compensate for an increase in volume. And you want to limit care activities if you're seeing this. If you're seeing a plateau wave or a P2 of a larger amplitude, so greater than 50 or between greater than 50 millimeters of mercury, these waves are clinically significant and demand immediate attention. We can tolerate an occasional B wave, a non-sustained ICP that's 25, 23 while you're suctioning, it goes right back down. But we want to make sure that we're calling the neurosurgeon and intervening when we're seeing larger waves. And especially if we're seeing a wave greater than 50, we're calling the neurosurgeon and getting immediate attention and response from them. So we have our Camino ICP monitor. We have our intracranial pressure probe, our bolt and probe for monitoring pressures. We'll have the intracranial access kit, which includes sterile supplies and a drill or drilling. Oftentimes this is done in OR, so you won't need to do this or worry about this, but I think the more eyes that are laid on this, the better, the more awareness and exposure, the better. I've seen ICP monitor placed, or ICP probe placed once in 4.5 years. So you don't see it very often, especially on nights. Well, probably more on nights than days because OR might have less availability. Anywho, so if you see the green label, that is the intracranial pressure probe, so it's not a drain. The blue label, think blue water drains. So that would be your external ventricular drain kit. So this is going to come with a drill bit that the physician, the neurosurgeon, is to use when placing, not the drill bit that comes in the cranial access kit. They should know that. It comes with equipment for prep and closure. It comes with the bolt and other stuff to use in conjunction with the bolt. Let's take a look. So here we have the bolt and catheter and the fiber optic cable here at the tip. So the surgeon would prep all of this and set this up sterilely. The surgeon would then unthread the bolt from the fiber optic cable. You'd just be there supporting and gowning him up and whatnot, or her. So I take the bolt off the fiber optic cable. Now the neurosurgeon is going to insert this into the patient's skull. You can see the threads that are actually threaded onto the skull. So they thread it in the hole that they drilled into the skull. So now it's in place in the skull. The important thing to note for nursing about this is that there's no really good way to secure this. You can't really tape it. You can't staple it, suture it. We place a tegaderm, but you have to have really diligent nursing care. Fiber optic cables are very fragile, so they can break easily. So you just need to be really, really careful. So the other important thing to note is that before this cable goes into, before the fiber optic cable goes into the bolt, it has to be zeroed, right? Just like we zero everything, it has to be zeroed to atmospheric pressure. Doesn't do us any good to zero it once it's in the skull. So this part is sterile. The cord coming off of the Camino monitor, called the preamp cable, is not sterile. So this is a bit awkward, but you're gonna hold this end. And I've seen a lot of people who will take sterile towels and kind of wrap it around their hand and this part of the probe. And so the neurosurgeon is going to be holding this end, and you're going to put them together. The bolt is in the patient's head, the fiber optic cable is out. So you're going to plug the monitor in, you're going to turn it on. You'll have that ready. It's saying plug me in. Plug in the preamp cable. So you have this side, the neurosurgeon has this side. They're going to plug it in before the fiber optic the fiber optic cable goes into the patient's skull to zero it to atmospheric pressure. Inside this kit is a tiny plastic flathead screwdriver, and on the surgeon's side is a little space for that to go to zero. Now, if this was a new catheter, it would give me an ICP and a green line here. And so the neurosurgeon would just turn this until that says zero. Since it's a educational catheter, it's been used and abused, it's not gonna read anything. I am dialing it and you can see the ICP number changing, but it's not giving me anything on the graph. So once you have it zeroed, you can wrap a towel around it. You have to be careful because this is close to the sterile field. And this is not sterile, and you've connected a non-sterile thing to a sterile thing. So you have to be really careful with that. So now the neurosurgeon is going to place the fiber optic cable in the bolt as such, and then this screws on to ensure that the cable is secure in its positioning. So he can unscrew it, and he can unscrew it a little bit to loosen it and make the cable go further in or further out. So this is one thing we know in terms of placement for nursing is they all have, this is an older one, but we see a little window here, and we want that red line to be within that window. So here it's fine, there it's fine, it's in the window, they're gonna place it. And then when we come out, you'd want to call for that. Same thing over here. The newer ones have either a red dot or a black dot, and similarly, you'll see a designated window there that has to be in between. So the neurosurgeon will set that, they will tighten it. It is zeroed. You've zeroed it with the neurosurgeon. Once the neurosurgeon has zeroed it, this probe, this cable goes into the patient's skull, and now you will never re-zero it again. Throw this in the garbage. If somebody re-zeros this while it's in the patient's skull, then it does us no good. So throw it away. A few things to note on the Camino monitor. It's going to give you an ICP here, a numerical value. It will give you a graph, and you can press this button to adjust the graph. So here we see 0 to 100. Now it's 0 to 200. Now it's -5 to 10. Now it's -10 to 20. Now it's 0 to 50. I like to keep it at 0 to 50 because you have this line at 25 and it gives you a value. So as it's creeping up, you'll see it. But if it fills, you know that is clinically significant. If it's above 20, you're going to try interventions. If it's above 50, you're going to be calling immediately. There's a few extra cables on here. So we used to stock this on our unit, but we decided let's just keep it on the Camino monitor because no one can ever find it. So you can plug this in your monitor and have that ICP be reflected on your monitor. These probes and this one on the preamp cable, this is for intracranial oxygen monitoring and intracranial temperature monitoring. So we don't have the equipment to support that. So you would not use these, you just ignore that. This button here that looks like a graph that shows you trend data over time, 12 hours, 24 hours. And then the systolic diastolic, if this was integrated to our monitor and the monitor was giving feedback to the Camino, not just the Camino reading to the monitor, you could see the systolic and diastolic. Now we have it set on CPP and ICP. So if you're transferring a patient to CT scan, all you will do is unplug this from the patient, secure this to the patient, ensuring that it doesn't come out, and then send the patient to CT. When you come back, all you'll do is plug it in. There's no zeroing involved. You'll never zero it again. If anyone's telling you to re-zero it, do not listen to them. You can't re-zero it. I mean, you can, but it will basically make the ICP monitoring null and void.